Today we're talking about our second section of the skeletal system. This corresponds to chapter 7. I have broken this one up into two. The first one we're going to do as a video. The second one, I'm just giving you the notes as a reference. This is going to be focusing more on the skeletal system anatomy. So with the other section of this, it will be more helpful for you to use as a reference guide for your lab in learning the bone markings on the different bones. So we're looking at the human skeleton here. It's got 206 named bones, and they're divided into two main divisions. We've got the axial and appendicular skeleton. The axial is going to be bones that lie around the longitudinal axis of the human body, basically the head and the torso. So it will include the skull bones, the auditory ossicles, which are the little tiny bones in your ears, the hyoid, the ribs, the sternum, and the bones of the vertebral column. The appendicular skeleton is going to be the bones of the upper and lower limbs, or your extremities, plus the bones that form the girdles that connect them to the axial skeleton. So that would be the shoulder girdle and the pelvic girdle. So this just gives you the divisions here, showing in bony colors for the black and white colors for the axial skeleton, and then black and white colors for the appendicular skeleton, and shows you how many bones are in each one. And the picture just a little bit larger here, showing the different individual bones. So the bones are based on their shape. We've got long bones, short bones, flat bones, irregular bones, sesamoid bones, and then the sutural bones, which are little bones that are located between the skull bones. So long bones are greater length and width. A lot of times they are slightly curved for strength. This would include the femur, tibia, fibula, humerus, ulna, radius, and the phalanges. Your short bones are more cube-shaped. They're nearly equal in length and width. This is your carpals and tarsals, or your wrists and ankles. Flat bones are thin and have two nearly parallel plates of compact bone tissue enclosing a layer of spongy bone in between. Cranial bones, sternum, ribs, and scapula are in this category. Irregular bones have more complex shapes, and they don't fit into any of the previous categories. These would include vertebrae, hip bones, some of the facial bones, and the calcaneus. Sesamoid bones, these are going to protect the tendons from excessive wear and tear. The patella is the main one. It's not unusual to see some little sesamoid bones occur in the foot and the hand. Then your sutural bones are small bones located in the sutures of the cranial bones. So bones have surface markings. They are the structural features that we can identify them for specific functions. So there's two major types, depressions and openings. These will allow the passage of blood vessels, nerves, or help to form joints. And then processes, which are surfaces, they're projections or outgrowths that form joints or surface attachment points for ligaments and tendons. So with the axial skeleton, it's going to be the skull, the hyoid bone, the auditory ossicles, vertebral column, the rib cage, so it includes the rib and the sternum. The skull is going to enclose and protect the brain and the special sensory organs. So your skull or cranium has 22 bones. They're divided into two categories. Your cranial bones, there's 8 of them that form the cranial cavity. Frontal bone, 2 parietal bones, 2 temporal bones, the occipital bone, the sphenoid, and the ethmoid. Your facial bones, there's 14 of these that form the face. 2 nasal bones, 2 maxillae, 2 zygomatic bones, the mandible, 2 lacrimal bones, 2 palatine bones, 2 inferior nasal conchae, and the vomer. So the cranial and facial bones are going to protect and support the special sense organs in the brain. So they'll form a large cavity, the skull, and then you'll have several smaller cavities within. Nasal cavities, the orbits or the eye sockets, paranasal sinuses, and then small cavities which house organs involved with hearing and equilibrium. So your skull joints are immovable joints called sutures. They will fuse most of the bones together. It's going to provide large areas for attachments for muscles that move various parts of the head. So a lot of times if you feel on your head and you go, it feels kind of good to give yourself a head massage, it is because you do have muscles covering a significant portion of your head. The skull and facial bones provide attachment for muscles that will produce facial expressions. These form the framework of the face. They're also going to provide support for entrances to the digestive and respiratory system. So basically your mouth and nose. So your skull bones, the frontal bone forms your forehead. The parietal bones are going to be the sides and the roof of the cranial cavity. The temporal bones are going to be the lateral aspects of the floor of the cranium. So they're going to be just inferior to the parietal bones. The occipital bone is going to form the posterior part and most of the base of the cranium. The sphenoid lies in the middle part of the base of the skull. And then the ethmoid is located in the midline in the anterior part of the cranial floor, medial to the orbits. So it's a major structure supporting the nasal cavity. It's going to have thin projections called the conchae, which are lined by mucous membranes. And the increased surface area here in the nasal cavity is going to help to humidify the inhaled air, trapping inhaled particles. So ideally, you want to inhale and breathe through your nose. So sutures are immovable joints that are going to hold most of the skull bones together. Your paranasal sinuses are going to be cavities within the cranial and facial bones near the nasal cavity. So paranasal means next to the nose. Secretions produced by the mucous membranes which line the sinuses will actually end up draining into your nasal cavity. And then they serve as resonating chambers that intensify and prolong sounds. So if you have sinus congestion, you'll notice that there's a change in the resonance of your voice. The fontanelles are seen at birth. It's unossified tissue spaces. We commonly just call them the soft spots on an infant's head. They are eventually replaced with bone to become sutures, but it's going to give more flexibility to the fetal skull. It will allow it to change shape as it passes through the birth canal. So here you can see these ethmoid cells in the sphenoid sinuses. The paired cavities in the ethmoid and sphenal, frontal, and maxillary areas. So you can see frontal, sphenoid, maxillary. So these are lined with mucous membranes. They'll open into the nasal cavities. They give that resonance. Sinusitis is inflammation of the membrane. This is typically what happens with allergies. So the hyoid bone, it does not actually articulate with any other bones, but it does help to support the tongue by providing attachment sites for the tongue, muscles, and some of the muscles of the neck and pharynx. It also helps to keep the larynx or voice box open at all times. Your vertebral column, also called the spinal column, your backbone, it's going to protect your spinal cord and support your head. This is where the ribs will attach, the pelvic girdle, and several muscles. So your vertebral column is curved to varying degrees in different locations. A lot of these curves are normal to have. The curves increase the strength of the column. They help to maintain balance in an upright position. They help to act as a shock absorber while walking or running. They help protect the vertebrae from fracture. And these curves are going to change from the birth time. When you are born, you're in a kyphosis. When you go to change a new baby's diapers, you notice the legs just keep folding up to their chest because they've spent the last 9 months developing in kyphosis. As you go to crawling and then standing, you will develop the cervical and lumbar lordosis, which will allow you to hold your head upright and look in front of you, as well as to stand upright and have your legs underneath you. So you can see here, single curve in a fetus, here in an adult. If you walk around with your head down all the time, you'll actually start to lose this curve, and it will lead to a lot of neck problems for you. So here you can see the cervical curve here. You've got a posterior curve. That's where you're going to have the lordosis and a lumbar lordosis. Here you've got this thoracic curve. That's your thoracic kyphosis. You'll notice there are not side-to-side curves. The side-to-side curves are the ones we refer to as scoliosis. So there can be conditions that will exaggerate the normal curves. So curve changes, they are generally going to increase with age. You see more kyphosis with somebody with osteoporosis, and the lordosis will increase with pregnancy. So when we look at the vertebrae, there are 7 cervical vertebrae in the neck region. There are 12 thoracic vertebrae. These are posterior to the thoracic cavity. They're the ones that attach to ribs. 5 lumbar in the lower back. You have a sacrum that's 5 fused sacral segments, and the coccyx, which is for fused coccygeal segments. So here you can see this is an example of someone with a scoliosis. This would be someone with a kyphosis, where there's just more rounding. Somebody with more of a lordosis. So these are not great examples, but it's what we've got. Your intervertebral discs are found between the bodies of the adjacent vertebrae. It's going to help give some strength to the joints and allow movements of the vertebral column. They will also act as a vertical shock absorber. So you can actually carry large amounts of weight around on your shoulders because of these discs. So a vertebrae typically consists of a body, which is the weight-bearing section of it, the vertebral arch, that's going to be the posterior part that's around the spinal cord, and then there'll be several processes that are going to stick out as points of attachment for muscles. So when we look at the intervertebral disc injuries, or the IVD, a herniated or a slipped disc is going to occur when the outer ring becomes weak or torn, and it's going to allow some of the inner portion to slip out. A bulging disc does not always affect the entire perimeter of the disc, but at least a quarter or half of the disc's circumference is usually going to be affected. The outer layer of tough cartilage is involved. With a herniated disc, on the other hand, this is going to result when a crack in the tough outer layer allows some of the soft inner cartilage to protrude out of the disc. So they're also called a ruptured disc or a slipped disc, although the whole disc itself does not rupture or slip out of place. So with advanced imaging technology, we have been able to see that there are actually a lot of these out there that are really pretty asymptomatic for people. So here, this is the anterior end and the posterior end of a vertebrae. You've got the body. So this is a thoracic vertebrae, so it's got a facet for the ribs to attach to. The vertebral foramen, that's where the spinal cord goes. So where this is going to attach to this little area is the pedicle. This is the superior articular process. These are going to articulate with the vertebrae above it. You've got the spinous process, the transverse process. This back section here is your vertebral arch. This is the lamina. And then you can see the intervertebral discs in between. So this is the side view. Where you have the pedicle here actually makes a little bit of an arch. This is where the spinal nerves come out. So the intervertebral foramina is 2 of these notches together that allow the spinal nerves to exit. So the spinal canal is created by all the vertebral foramen together. So the regions, the cervical region is C1 through 7. The first 2 bones have unique names. The atlas C1 is the first cervical vertebra. The axis C2 is the second cervical vertebra. They also have significantly different shapes than the rest of them. The thoracic region, you've got 12 thoracic vertebrae that are going to articulate with ribs. In the lumbar region, it's L1 through 5. These provide attachments for the large back muscles. The sacrum is a triangular shaped bone. It's 5 fused segments, S1 through 5, that comes together that makes a foundation for the pelvic girdle. And then the coccyx, like the sacrum, is triangular in shape. It's formed by the fusion of what's usually 4 coccygeal vertebrae, and sometimes that number will vary a little bit in there. It's way down at the bottom. So way down here is where you would have the coccyx. So you can see here with the cervical vertebrae, you've got C1 and C2. They do have a unique shape. So right here on C2, you've got the dens that's actually going to protrude up into this little space here, and you would have a ligament beyond that. So most of your side-to-side motion comes at C1 and C2 being able to twist. So the atlas is this ring-shaped bone. On the top here, you've got your superior facets. This is where the occipital condyles of the skull are going to sit on and allow for a little bit of nodding movement here. You also get a lot of that movement at C5 level. So here is the axis on C2, sometimes called the dens or the odontoid process, that will stick up here and allow that pivoting motion. So your thoracic cage, you have the sternum, the ribs, there's 12 pairs of ribs, 7 true ribs. True rib is going to go from bone in the back to bone in the front. 5 false ribs, it goes from bone in the back to attaching to cartilage in the front. And then below that are 2 floating ribs that attach to bone in the back, but they don't attach to anything in the front. So the thoracic cage also includes those costal cartilages that those false ribs attach to, and the thoracic vertebrae. It's going to help to enclose and protect the organs in the thoracic and abdominal cavities. It's going to support the bones of the upper limb. And then it's going to be involved with breathing because you're actually going to have the rib cage change shape in order for you to be able to inhale and exhale. So the sternum is sometimes called the breastbone. It's in the center. It's going to have the manubrium, which is at the top. The body is the main part of it, and the xiphoid process down at the bottom. So with ribs, again, true rib, bone in front and back, false rib, bone in back, cartilage in front, floating rib, bone in back, no attachment in front. So those costal cartilages are going to contribute to the elasticity of the thoracic cage. If you put your hands around your rib cage right now and you take a big breath in, you can feel that the rib cage has quite a bit of movement in it. The appendicular skeleton's main job is to be able to move. It's going to be your upper and lower limbs, as well as the girdles that are going to attach these to the skeleton. So your pectoral girdle is going to have 2 bones, the scapula and the clavicle. The free part of it has 30 bones, a humerus, an ulna, radius, 8 carpals, your wrist bones, and 19 metacarpals and phalanges in your hands. The clavicle, sometimes called the collarbone, is kind of an S shape. The medial end of it articulates with the manubrium of the sternum, making the sternoclavicular joint, sometimes called the SC joint. The lateral end articulates with the acromion, making the acromioclavicular joint or the AC joint. The clavicle is convex, anterior, and near the sternal junction. It's concave anterior on its lateral edge near the acromion. So you can see here some of the points on there, the conoid tubercle. So here's the impression the costoclavicular ligament is going to leave. So you can see this in your shoulder. If you put your hand on your clavicle, you can actually feel that this bone does move. If you lift your arm overhead and bring it back down, you can feel the movement in there. So fractured clavicle. Fall on an outstretched arm injury can lead to a fractured clavicle. It's the weakest at the junction of the 2 curves. And the forces are generated through the upper limb to the trunk. So most breaks occur approximately in the middle of the clavicle. So not a fun injury. So looking at the scapula, the spine is a large process on the posterior of the scapula. It ends laterally at the acromion. When you feel your shoulder blade on the back, this is the ridge that you feel going horizontally. The acromion is the flattened lateral portion of the spine at the scapula. The coracoid process is a protruding projection on the anterior surface. It's just inferior to the lateral aspect of the clavicle. So it's where you're going to have your clavicle meet up with it. The glenoid cavity is going to be the shallow cavity that's going to articulate with the head of the humerus. This is a shallow cavity, so dislocating the humerus is a lot easier to do than to dislocate the pelvis. So the joint between the humerus and the glenoid cavity there is referred to as the glenohumeral joint. Subscapular fossa, it's going to be the anterior concavity where the subscapularis muscle attaches. It's basically going to be the surface that's between the scapula and your torso. The supraspinous fossa is a posterior concavity superior to the scapular spine. This is where the supraspinatus muscle will attach. And the infraspinous fossa is the posterior concavity inferior to the scapular spine. That's where the infraspinatus muscle attaches. So your arm or humerus, this is the longest and largest bone of the upper limb. The proximal ball-shaped end is going to articulate with the glenoid cavity of the scapula. The distal end will articulate with the elbow, with the radius and the ulna. So the head of the humerus has two unequal sized projections. The greater tubercle is going to be more lateral. The lesser tubercle is more anterior. And then between the tubercles, you have the intertubercular groove or sulcus, sometimes called the bicipital groove. This is where the long head of the biceps brachii tendon is located. So if the arm is rotated a little bit funny in there, you can have impingement occur if that tendon is not lying right in the groove. So the shaft of the ulna and radius are going to be connected by the interosseous membrane. You've got a proximal radial ulnar joint and a distal radial ulnar joint. So at the proximal end, the head of the radius articulates with the radial notch of the ulna. At the distal end, you're going to have the head of the ulna articulate with the ulnar notch of the radius. So looking at the hand, the carpals make up your wrist. It's 8 small bones. It's 2 rows. The proximal row is going to be the scaphoid, lunate, triquetrum, and pisiform. The distal row is going to be the trapezium, trapezoid, capitate, and hamate. The scaphoid is the one that is most commonly fractured. So it just has to do with if a person falls and they put their hands out in front of them to try and catch their fall, the pressure goes onto that bone. The carpal tunnel is the space between the carpal bones and the flexor retinaculum. So you have your proximal row that goes lateral to medial. So the scaphoid, it's called that because it's boat-shaped. The lunate is moon-shaped. The triquetrum got the name because it has 3 corners. The pisiform is P-shaped. So this is what's in the distal row going from lateral to medial. So you have 5 metacarpals. We number them 1 through 5. They go lateral to medial. You have 14 phalanges. So it doesn't mean you have 14 fingers. You just have 14 phalange bones. There's 2 in the thumb. The thumb is also called the pollex, and 3 in each of the other fingers. Each of the phalanx is going to have a base, a shaft, and a head. So the joints, you've got the carpometacarpal, metacarpal phalangeal, and the interphalangeal joints. So they're named by the 2 bones that make up the joint. So here you can see where you've got those carpals lined up. And then up in here where you would have the carpal tunnel. It's the tunnel of the bone and the flexor retinaculum. So it basically is going to be a band that wraps around the wrist and holds a little bit of an arch in there for things to be able to pass through. So again, seeing some more pictures. So there is some mnemonics out there. Sally left the party to take Carmen home. There are several different mnemonics out there to help you remember the bones of the wrist. Pick which one that works for you. So for the lower limb, you've got 2 separate regions, the pelvic girdle, which is 2 bones, and then the free part, which is 30 bones. So the hip bones are the coxae, is going to be made up of 3 bones that are fused together, the ilium, pubis, and ischium. They're joined anteriorly by the pubic symphysis, which is fibrocartilage. And then they're joined posteriorly by the sacrum, and that forms your sacroiliac joints or SI joints. So here you can see where you'd have the SI joints. Here is where you would have the pubic symphysis. This one illustrates the 3 different bones, the pubis, the ischium, and the ilium. And then you've got the sacrum there. So the ilium is the largest of the 3 hip bones. It's the superior part. It's going to have the superior ala, which are the sides, and the inferior body, which will form the acetabulum, which is the socket for the head of the femur. The superior border forms your iliac crest. So hip pointer occurs at the anterior superior iliac spine. So here you can see this would be your anterior superior iliac spine up there. And then your greater sciatic notch. This will allow the passage of the sciatic nerve. So it is a big notch because that's a big nerve. The ischium is inferior and posterior, part of the hip. The most prominent feature is the ischial tuberosity. That's the part that should be on the chair when you're sitting if you're not slouching too much. The pubis, inferior and anterior, and it's going to have a superior and inferior rami and body. So the pelvic brim is a line that's going to go from the sacral promontory to the upper part of the pubic symphysis. The false pelvis lies above this line. So it contains no pelvic organs except the urinary bladder when it's full and the uterus during pregnancy. So the true pelvis is the bony pelvis inferior to the pelvic brim. It's got an inlet, an outlet, and a cavity. So the pelvic axis is the path the baby takes during childbirth. So here you can see a false pelvis and the true pelvis in here. You can see this line that is going to form here for the sacral promontory down to along the front for the pelvic brim. So male and female pelvis is going to have different shapes. If you take a look at them here, on the left you've got the female, on the right you've got the male. In general, in the female, it's going to be light and thin. In the male, it's heavier and thick. The false pelvis is shallow in a female but deep in a male. The pelvic brim is larger and more oval in a female. It's smaller and heart-shaped in a male. The acetabulum is small and faces anteriorly in the female. In the male, it's larger and faces more laterally. The obturator foramen here is going to be oval in a female. It's more round in a male. The pubic arch in a female is usually greater than 90 degrees. In a male, it's usually less than 90 degrees. So also, you're going to have differences from the lateral side here in a female. So the iliac crest is less curved in a female. The ilium's less vertical in a female. The sciatic notch is wider in a female. The coccyx is more movable and more curved anteriorly, where in a male it's going to be in closer. The sacrum is shorter and wider in a female, less curved anteriorly. It's longer and narrower in a male with more curve anterior. So when we look at the pelvic outlet, it's wider, shorter, and farther apart, and more medially projecting in a female. So the reason for these differences is to be able to give birth. So your lower limb, this is going to transfer body weight to the ground, allows walking. It's going to have the femur, which is your thigh, the patella, the kneecap, the lower leg, which is the tibia and fibula, tarsals in the ankles, metatarsals, feet bones, and the phalanges are your toes. So here is just showing all of those different bones. Your patella is the largest sesamoid bone in the body, makes your patellofemoral joint. The superior surface is the base. Your inferior narrow surface is the apex. You have a thick articular cartilage lining the posterior surface. It increases the leverage of the quadriceps femoris muscle. So patellofemoral stress syndrome, or runner's knee, is a common affliction that goes along with this. So while it is a sesamoid bone, it does have a particular groove that it's supposed to sit in, and if it doesn't sit in that area, it will be easily irritated. So looking at the foot, there are 7 tarsal bones. The talus is going to be what articulates with the tibia and fibula. The calcaneus is the heel bone. It's the largest and the strongest. And then you've got the navicular, the cuboid, and 3 cuneiforms. So your 5 metatarsals, they all are going to have a base, shaft, and a head. And then you've got 14 phalanges, so it's not 14 toes, 14 phalange bones. The big toe is the hallux. The tarsus is the ankle. So this allows you to see these different bones in the ankle. You've got your navicular here, the talus, calcaneus, the cuneiforms, the cuboid. So you actually have 3 arches in the foot as well. So you've got the medial part of the longitudinal arch here. You've got, well, this is your transverse arch. You've got the medial part of the longitudinal arch, and then the lateral longitudinal arch. This arch here, this medial arch, is the one when people talk about the arch of their foot. That's primarily what they're talking about. But the foot is also elevated here in the whole center section, and it's elevated a little bit to the side as well. So it is a 3-dimensional structure. So most of the skeletal tissue is going to come from mesenchymal cells. The skull is going to develop during the 4th week after fertilization. So those fontanelles between the skull bones will be there the entire fetal life as well as part of infancy. The upper limb buds are going to form during the 4th week after fertilization, followed by the lower limb buds. During the 6th week, we see the hand and foot plates. The vertebrae and ribs are formed from the sclerotomes of the somites. So when you have proper development of the vertebral arches fail, we call that a spina bifida, and that can have varying degrees of severity. So this lets you see where you've got the start of those skull bones in a fetal head. So here is showing 4 weeks, 6 weeks, 7 weeks, 8 weeks. So within that 4 weeks there's pretty significant changes that occur. So the skeleton can reveal important information about a person. There is some differences from race. We tend to see people of African descent will have greater curves in their spine. People of Asian descent tend to have less curvature to their spine. It can give indication of medical history, the gender, the body size, the muscle mass, as well as the age. So there are some general changes in the skeletal system that take place as you age. So this is going to give you some differences in the male and females. So the shape of the forehead is more sloping in a male. The general appearance, heavier, rougher surface. Sinuses are larger in a male. The cranium is larger in a male. Mandible is larger, more robust. The teeth tend to be larger. The pelvis in a male, narrower. Heart-shaped pelvic inlet. Deeper iliac fossa. The ilium is more vertical. The anterior, inferior, the angle inferior to the pubic symphysis is less than 90 degrees in a male. Acetabulum directs laterally. Obturator foramen more ovally. Ischial spine points medially. Sacrum is long and narrow, more pronounced sacral curvature. In general, the skeleton is heavier in a male and more prominent. So as we get older, the bony matrix will reduce its mineral content. This begins at age 30 to 45. It does differ for males and females. You have similar reductions occurring in both sexes after age of 65. So hormones are definitely going to play a role in this. The markings, they're going to be reduced in size and less rough. So changes in the skull. The fontanelles close by age 2. Frontal suture fuses from age 2 to 8. The occipital bone, you have fusion of the ossification centers between ages 1 and 6. The styloid process will fuse with the temporal bone between ages 12 and 16. The hyoid bone has complete ossification and fusion somewhere between age 25 or 30, sometimes a little later. You lose the baby teeth. That will vary. That's throughout childhood that happens. The mandible, as you get older, you have loss of teeth, reduction of bone mass, and a change in the angle. This accelerates quite a bit in the later years after age 60. So for the curves, you're going to develop them between 3 months and 10 years in childhood, but they will also change as you get older. You'll increase in curvature a little bit, as well as having the intervertebral discs reduce in size, accelerating more quickly after age 60. So basically you're going to get a little shorter. With the long bones, the epiphyseal cartilage is going to fuse. It's going to depend on that, usually by your early 20s. The pectoral girdle and pelvic girdles are going to begin to fuse as you get older as well.